Thanks again for the opportunity to talk about mental health care again in a HIV focused conference. So the topic of my talk is really to bridge the gaps of the service that we already have in our clinic for our patients. So two simple, I think very digestible topic. Number one, I'm just going to share with you a story of Bobby. Number two is I'm going to give you an overview of the ID Wellness Clinic that we run in University of Malaya Medical Center in Malaysia. So, in 1982, Bobby was born as the first child in the family. As the only child and the first child, he gets all the attention from the parents. He's the only person in the family that requires care, love, so he gets everything. So he's a happy boy. 4 years later, Bobby's mother gave birth to a baby sister with cerebral palsy. And suddenly, Bobby's life has changed totally. Not only he did not get 100% attention from the parents, now his parents basically just focus on the baby sister who has more needs than him. And suddenly, the nurturing mother has become, he would describe as an angry lion. What the tiniest mistake that he does, he gets scolding, he gets punishment. And all the playtime that he had before the born of his sister has now turned into hospital and clinic visits alongside with the parents just for the baby sister. What is making it worse is that the mother has started to restrict visits from other family members into their house because she thinks that the other relatives, they do not understand the medical condition that the sister has, and they are laughing at them at their back. So from then, Bobby learns that, I don't really have to share with people what I'm going through. Nobody really cares. I just need to hide my negative feelings because whenever I say it, I voice it out, I get scolded, I get punished. Things change a little bit later on when he's got a baby brother, a healthy baby brother. And he's happy again because finally he has a new playmate. And with the trauma that the family went through with the baby sister, they just love this boy extra, you know. And they were happy for a while. And when Bobby was 18 years old, one random night, the baby brother, not baby anymore, 12 years old brother, was feeling unwell. The family rushed him to the emergency department. And on that day, the father was away for work. So Bobby and the mother sent the brother to the hospital. And on that very night, the brother passed away unexpectedly due to ruptured aneurysm. Is that what you call in the medical term? It was a sudden death. And when all this happened, the brother was laying on Bobby's lap. And when that happened, the mother passed out in the hospital emergency department. So who has to deal with all the other things? Bobby. So as a 17-year-old boy, he said, I don't remember dropping a tear because I really have no time. The medical doctors came to me and asked me, what's the name, what's the identification, all the paperwork has to be done. And my mother wasn't there. So I have to be there. I have to be strong. And after the passing of the brother, the mother actually packed up every belonging of the late brother and just trashed it away. That's her way to deal with the pain that she's going through. And whenever Bobby asks about the brother, wanted to talk about it, he will get scolded. So from that night onwards, nobody in the family can talk about things of that night. From that, he learns that few things. I have to behave, because if I don't, I'll get scolded. I do not want my parents to go through whatever negative emotions that they have been through already. I have to take care of my sister. And I have to study hard, work hard, because the whole family depends on me. Because, quote unquote, the parents, I am the only healthy child left. So what about Bobby in the ID clinic? I don't know whether the story of Bobby reminds you of any patients of yours if you are seeing patients in your clinic. So he got diagnosed with HIV in 2014, started hard 3 years later with good CD4 and quite a low baseline RNA. So after starting treatment, the viral load has been undetectable ever since the first day of treatment. And 4 years later, he got tested positive and treated for gonorrhea, chlamydia, syphilis in the same visit. However, in the clinical notes, he didn't share much of his personal life, especially sexual life. And I expect doctors doesn't really ask much as well. So in a busy HIV clinic, we would see Bobby as a good patient, stable on heart, with undetectable viral load. That's how we label them in our mind, isn't it? Don't lie. So these kind of patients, we will give the minimal attention to, because it's just such a busy clinic, right? And in December 2023, for the first time, he shared with the ID doctors that he was seeing a private psychiatrist for mood and sleep, because he couldn't sleep because there's just too much stress at work. And then the psychiatrist started antidepressant for him, and he stopped the medication 9 months later because he said he's coping better. 2 months later, in October last year, he first told the doctor about chemsex, and he said, I've been using it for 10 years actually. 1 month later, as a program that we have in the ID clinic under the MIN study funded by Treat Asia, he was screened by the study tool. It's a DIY study tool that he screened for 6 mental health condition. And for mood condition, he was okay. But he was flagged for moderate risk of meth use. Then he get referred to see the in-house psychologist, which is me. So for the substance use history, he mainly used meth. He tried G, he tried the other, but mainly the addiction is to meth. And initially, he started off just puffing. But as some of you might know, if you have used it for some time, you develop tolerance. So puffing meth is not enough anymore. Then he started injecting. He said it helps him to connect to his sexual partner, and it enhances the sexual performance. The withdrawal syndromes that he reported was he felt depressed, he couldn't sleep, he was tired, and he was paranoid, especially after he started injecting. And all these things has affected his work. He was also in a relationship with a female partner. It affected that relationship. And the parents noticed the change of behavior and took him to the psychiatrist. That's when he got started on antidepressant, where he claimed that he was there for sleep issue. So last year, he started to see the psychologist, me. He attended 6 therapy sessions with me. The focus of the therapy really for the first 2 sessions is really to help him understand about a different chemical, different substance that he might be using. And what we did is really a harm reduction approach. It is not to just stop everything, to ask him to stop everything, but it's work with the goal that he set, to use it safely, to reduce the usage. Motivational interview also being used. Mindfulness help him to cope with some craving. And the session later on focus on the process of the emotional pain, the underlying emotional pain that cause for the depressed mood and subsequently substance use issue. So we also talk about the brother's death, because he said that he never ever tells somebody that he has a sister. He always tell people, including the doctor, that he's the only son. So he said, it's weird for me to tell you this, but actually I have a sister and a brother who passed away. So from these 6 sessions that we have gone through, he knows better about the triggers for his substance usage. He knows when he's hit by the negative thoughts in his mind and the reason why. He's also more self-accepting. So he doesn't rely on other people's approval. So he thinks he's good enough. And because of that, there's reduction in meth use. Things that we can learn from his condition include silent suffering. You know, when we see a good patient, that doesn't mean there's no issue. That doesn't mean that there is no distress emotionally for that person. And I think something that we have to reflect on is that why he took so long to share with us. He has been using substance for 10 years. And I think many of the medical professional doesn't really quite familiar with this idea. The intersectionality of different stressor can actually make it worse, because it makes someone to experience so much pain that they go to a fix quick kind of coping mechanism, such as substance use. Trauma and grief, if they are not being processed properly, then they will turn into low mood. Summary, it's important to understand the need for the integrated HIV and mental health care. But for us to know the issue, the next thing we have to do is that we have to have routine mental health screening. And because of that, substance use disclosure was so difficult, it's also important to advocate for non-judgmental environment for all this assessment. And also, as a psychologist, I would strongly encourage doctors to explore not only explore the medication for mental health, but the therapy intervention. So this lead me to introduce you proudly of the ID Wellness Clinic that we have in UMC Malaysia. So we started in January 2024 with just new case counseling for newly diagnosed patient and serodiscordant couple. This is led by a nurse educator. And I'm there to provide therapy for patients who screen positive for mental health screening, but mainly under the research setting, for patients who request for mental health care who uses substance. Now, we have mental health screening embedded in the clinic that is led by a nurse educator. So she does it once a week on a not so busy clinic, because we couldn't get her out full time to do the screening yet. And another good news is that we also got in-house psychiatrists to come to our ID clinic once a month to see our patients. And the key point that I highlighted here, that's the only underlying words that I have in my slide. We only prescribe medication if the patient agreed to medication. And most of the time, these patients are already under psychotherapy. So this is us in the ID Wellness. So I think what has helped us to build this ID Wellness is really multiple effort and connection, support from not only the ID team, but it also includes so many collaborators, including Treat Asia. So the MIN study is funded by Treat Asia. It's a multi-site mental health and HIV service integration in the Asia Pacific. So we have that tool that allow us to screen for 6 conditions at one go. It is self-administered as well. It is using electronic based device. So the screening part, let me try this. So with that tool itself, we got 51% positive rate from this one. And in the ID clinic, we actually added in a further assessment that's automated in the same interface leading from here. So patients, they don't really realize that they have moved on to the next phase. So we screen further for different conditions, and then that has helped the ID Wellness Clinic to reduce the patient burden and filter out patients who has more urgent need to 22%. So from the referral that we have given out from the screening, the attendance means that there's 82% of the patient actually came back for mental health care, which I think is quite high in this sense. And then, if they are screen negative, they were given 1-year appointment for that screening again. And also, with that project, we have built a referral pathway, because one of the reasons why when we interview healthcare provider, what can help you to screen and treat mental health condition in the ID? And they say, we need a protocol, a SOP. So we have that. And the referral pathway is really depending on the severity of different condition. You can see if they're negative, they get annual screening. If it's moderate, then they get a next slot available with a psychologist. And if it's urgent, they get a same-day referral. And if it's a severe condition or a high suicide risk, they get to see the psychiatrist on the same day. So lesson learned from trying to develop mental health service for the patients include task shifting, because we are all so tied down with our work. We have to task shift to a non-specialized healthcare provider. In our case, it's the nurses. And I think we're going to explore on moving it to the peer that is attending the ID clinic. And the use of technology can help with the human resources limitation, just like how we animated the screening process. And I think it's important to know that I think the generic referral process is really to write a referral letter, give it to the patient. Whether the patient end up at the other site for care, we don't know. For me, I think it's important for us to bear in mind that we have to build the service within the ID medical system. A key point that we have learned is that we need to get a key champion from the other side. If for mental health, it will be a psychiatrist who believe in the work that you are doing and trying to make a difference, and that has helped us in our setting. Continuous mental health training for the ID provider, including the nurses and the doctors, is also ongoing annually. I'm actually thinking that we have to start planning for the future leadership to make that service sustainable. Because we have seen some services develop in our setting that wasn't sustainable because there's really no future leadership involved. So I would like to say big thank you for the ID doctors in the room and back in the clinic now in Malaysia. And the nurses, I don't think it's possible without the support from the nurses in doing all this work. And of course, our study team, the Treat Asia team, MCounseling team, and of course the patients who we are serving. Thank you.
Yeah.